Good morning, everybody. Welcome to Pediatric Grand Rounds. We have a lot more people attending today by WebEx than in the room, but thank you all for being here in either form. If you are here on WebEx and you have a question or comment for our speakers, please make sure to enter that into the chat with everyone box, and I will ask it to our speakers at the end of the presentation. Also, you'll be getting an evaluation for this presentation at the end at sometime today from our team. Please make sure to fill that out for us. And finally, just from our planning committee for Grand Rounds, we have no relevant financial relationships to disclose. And from here, I'll introduce our two fabulous speakers for today. We have Dr. Mary Crocker and Dr. Robin Ortenberg, who are both members of the Division of Pulmonary and Sleep Medicine here at Seattle Children's Hospital and the University of Washington. Thanks so much to both of you for being here. I'll take it away. Thank you.
Hi, I'm Robin Ortenberg, and I'll be starting us off today. The title of our topic is Inequities in Pulse Oximetry, Understanding the Limitations and Taking Action. For our objectives, we hope that throughout this talk, you will be able to evaluate the risk of occult hypoxemia in a clinical setting, analyze the root causes of bias in pulse oximetry measurements, and then together with us, hopefully hypothesize individual, organizational, and systems levels actions that can improve the objectivity in the evaluation of oxygen saturations in our patients and ensure equitable care to all children. Neither Dr. Crocker nor I have any financial disclosures. And I want to start just by giving some context. We in medicine place a really large emphasis on objective data when we're doing a patient evaluation. And specifically, we look really closely at vital signs. These are easily measurable data points that can be trended over time, and they're thought to give us some of the best indication of overall organ function and severity of illness in any patient. And for a long time, we had 4 vital signs that we looked at: heart rate, respiratory rate, temperature, and blood pressure. However, over the last few decades, oxygen saturation, as measured by pulse oximetry, has become more and more invaluable to our patient evaluations. And there's a lot of reasons why pulse oximetry has become so prevalent and used in so many different areas of the medical field. First, it's affordable. A finger pulse oximeter can be bought for $10 or $15 online. It's portable. So we use pulse oximeters on patient beds as they transfer from the emergency room to their patient room to the operating room, because it gives us some sense of stability about how they are as we move them throughout the hospital. They're widely available. You can buy them from any number of websites, and they're easy to use and interpret. You have 2 numbers usually, a heart rate and an oxygen saturation, and a waveform of some sort that tells you how well the machine is picking up. And then, unlike things like heart rate or respiratory rate or blood pressure, we don't have to think about how values change with age. So you don't have to compare the oxygen saturation of a 6-month-old to a 6-year-old. For the vast majority of patients, there are normal and abnormal values. And for these reasons, pulse oximetry has been integrated into health systems around the world. So just to give a few examples, the WHO publishes the Pocketbook of Hospital Care for Children. And this is both a book and an app that is really geared towards community health workers in rural or developing settings who have limited resources, with the idea of providing them algorithms as to how to diagnose things like pneumonia or malaria. So even with the idea that these are people who may not have a lot of medical infrastructure around, the WHO still integrates pulse oximetry into a number of its algorithms. When we think about new babies, one of the first things we do is put a pulse oximeter on them as we do neonatal resuscitation. And one of the first tests they undergo is testing for congenital heart disease, where we look at different oxygen saturations in various appendages as a marker for a possible underlying cardiac defect. And perhaps at no other time has oxygen saturation been as highly used and valued as during the COVID-19 pandemic, when medical facilities were just strained by the huge number of patients that needed evaluation, and they had really limited resources of both beds and oxygen. And oxygen saturations and pulse oximetry became a really important way for emergency rooms and medical providers to decide who needed to be admitted, who was able to convalesce at home, who needed the ICU, all of those things. Bringing this closer to home, so I went through all of our clinical pathways at Seattle Children's, and this is a not comprehensive list of each one of those that uses oxygen saturation and pulse oximetry as a branch point in our decision making. And many of them might seem kind of obvious, right? We would expect that oxygen saturations would be highly valued when you're thinking about diseases like asthma and bronchiolitis and croup. However, I think it's important to note that we also use oxygen saturations for postoperative care, as well as we look at it specifically in subsets of patient populations like children who are in diabetic ketoacidosis or patients who have sickle cell disease during times of acute illness. So even locally, we've really integrated pulse oximetry into our standardized pathways. So how do pulse oximeters work? And I'm going to do this at the very basics. I'm not going to get into the nitty-gritty of the physics of it. Let's say you have a pulse oximeter wrapped around your finger. At one end is a diode that emits light, namely two wavelengths, red and infrared light. And on the other end is a detector that looks at how much of that light passes through the finger and is absorbed at the other end. And we know that hemoglobin that is attached to oxygen, so oxyhemoglobin, absorbs more infrared light, and hemoglobin that is not attached to oxygen, deoxyhemoglobin, absorbs more red light. So as these wavelengths pass through the finger and are absorbed on the other end, that detector then looks at the ratio of infrared to red light and uses that to give you an oxygen saturation. There are other ways of checking oxygen levels. The gold standard remains an arterial blood gas. However, arterial blood gases require a poke, a stick, a blood draw, and in that way are invasive and are very difficult to get on kids who are not sedated. They also require a laboratory and an infrastructure, which not every facility might have. There are other options, like just looking at a child and seeing how cyanotic they look and their overall skin color, but this has not been validated to help us in any way figure out the severity of disease. And then there's other things like co-oximetry, which measure other types of issues in the blood like carbon monoxide, things like that, but it has not been used routinely to look at oxygen saturations. And we've been okay with that because for a really long time, we all thought that pulse oximeters were really accurate devices. The American Thoracic Society has a statement that says the oxygen level from a pulse oximeter should be accurate within plus or minus 2 compared to what you would get on arterial blood gas. And this is made from initial calibration studies that were done when pulse oximeters were being developed in the late 70s and early 80s. And what that means is if you have a pulse oximeter and your saturation is 92%, you can think pretty reliably that if I was to get an arterial blood gas, that oxygen level would be somewhere between 90 to 94%. And we've known about limitations. Anyone who's tried to get an oxygen level on a squirmy child understands that when kids are moving, it does not pick up, or when their hands are really cold. There have been numerous studies looking at how these wavelengths are absorbed in different colors of nail polish or in people who are wearing artificial nails. We know that oxygen saturations less than 80 aren't as valid and that it can be difficult for these machines to pick up in people who have really coarse, callous skin. And we also know that it may not be as valid in smokers. And then the last limitation, which is what we're going to focus the rest of our talk on, is how accurate are pulse oximeters in people with different skin colors. So when pulse oximeters first came out and first became widely used in the mid-'80s, as with any new machinery, people looked at them and really evaluated them and tried to figure out how well they would work in the medical setting. And so I thought this article by Kelleher from 1989 in the Journal of Clinical Monitoring was really insightful. So 5 years after these pulse oximeters had been widely available, he wrote an analysis of them and mentions that slight variations in pulse oximeter error have been detected by some investigators in Black adults and Black infants when compared with lightly pigmented patients. Other studies find no effect. It remains to be explained whether these differences might be accounted for by differential changes in red and infrared transmission. The other thing that he astutely notes is that it is noteworthy that individuals with dark pigmentation have generally not been used by manufacturers to generate pulse oximeter calibration curves and algorithms, which means that when they were first doing this technology, they were really looking at how it functioned on people with lighter skin color. And then this kind of just went out into the ether, and we didn't hear a lot about it for decades. It wasn't anything that I thought about or learned about when I was in medical school or residency. I would say the starting point for new discussion really came in 2020 in the midst of the COVID pandemic, when Schoeding et al. Published this letter to the editor in the New England Journal of Medicine looking at racial bias in pulse oximetry. And what they found is occult hypoxemia in patients who self-identify as Black. And we're going to get into the definitions in a little bit, but basically what we're talking about are falsely elevated oxygen saturations on pulse oximetry compared to what you might get on a blood gas. And they did a single and a multi-center analysis. In their single center at University of Michigan, they looked at almost 11,000 data points of critically ill adults and found that occult hypoxemia, or falsely elevated pulse oximetry levels, were found in 11.7% of Black patients compared to 3.6% of white patients. And then they expanded that to a multi-center analysis of 37,000 data points and found that it was still true, and that occult hypoxemia was noted in 17% of Black patients and 6.2% of white patients. And overall, Black patients were 3 times more likely to have falsely elevated pulse oximetry reading. And so I want to pause here and introduce some of the concepts of equity, diversity, and inclusion that are really essential to this topic. When we talk about how pulse oximetry works in one person compared to another, what we're really talking about is how this functions on a cellular level. There is melanin produced in melanosomes in the epidermis of the skin, and it's thought that the more melanin that is produced not only leads to darker skin, but that melanin can affect the absorption of red and infrared light as it passes through the skin. So that is what is going on a cellular level between people who have 2 different skin colors. However, we know that skin color is often associated, if not intrinsically tied, to social concepts and constructs of race and ethnicity and identity. And we also acknowledge that people who identify as Black, Indigenous, or persons of color have a history of medical bias, racism, and exclusion that has at times prevented them from getting appropriate care, and at other times prevented them from being appropriately used in research studies, such as in the calibration of pulse oximeters. And you'll see that this is an issue even for researchers as we go through the evidence. Because there is no standardization of skin color in an objective way, a lot of studies use self-identified race or ethnicity as a proxy for skin color, which we all know is not necessarily true. Dr. Crocker and I have tried to be really specific as we go through the talk with the words that we use, and to make sure that we are using whichever terminology best applies to the detail that we're speaking of at that moment. And so with that, I'm going to turn it over to Dr. Crocker to go through some of these studies.
So thank you, Dr. Rodenberg. That was super informative. And I just wanted to echo what Robin said, that we spent a lot of time kind of grappling with how to talk about this issue. And also, we're really cognizant of the fact that she and I are both women that identify as white. And so we are privileged in the fact that we likely have not been a victim of this type of bias. And so we are totally open to input from others and further conversation about how we've interpreted this. And so I appreciate your understanding with that. So next, I'm just going to go into a little bit of the research that's been done in this area specific to kids. And first, to kind of understand this research, I think we need to get on the same footing with the terminology and the way that studies have described inaccuracies in pulse oximeter readings. And so, first of all, just the basics. SpO2 is the peripheral oxygen saturation as measured by pulse oximeter. SaO2 is the arterial oxygen saturation as measured by the arterial blood gas, or ABG. And so there's this concept of pulse oximeter bias, which is a term that's been pretty uniformly defined across the literature, which is the peripheral oxygen saturation minus the saturation from the arterial blood gas. And so this is actually a number that's expressed by percentage points. And you can look at the mean bias across a group of people to get a sense of what the average of that is. And so from the get-go, we're just, since we know that no medical device is always accurate, we're going to have to assume that there's going to be some error for all patients. But what we're interested in here is whether there is error that's larger for one group of patients than another, which would be a health disparity. Another measure that's frequently looked at is the extent of occult hypoxemia, which Dr. Ortenberg already mentioned. And that's defined as a situation where the oxygen saturation by pulse ox for a patient is normal, but their blood gas is not. So basically, the pulse oximeter is overestimating the arterial blood gas value, or a false negative result from the pulse ox. And this can be operationally defined a couple different ways depending on what population and kind of their the range where you're more clinically concerned. But typically, it's been defined as a saturation from the pulse ox of 92 or greater, where the ABG is 88% or less. There have been other studies that have looked at this slightly differently. So that's how we look at defining inaccuracy, but how do we identify if there's a disparity? And there's a few different ways studies do this, but across the board, we need to compare between groups and find out if one group is experiencing more of an issue than another. And what we can compare between those groups include these things, which are we can look at the magnitude of the pulse oximeter bias, so the actual number. Is there a larger error in one group versus another? We can look at the sensitivity and specificity of pulse ox for detecting hypoxemia between groups. Or looking at occult hypoxemia, like is one group experiencing this phenomenon of occult hypoxemia more often than another, or just the odds of experiencing occult hypoxemia in one group versus another. And so with that, in the next couple slides, I'm going to go through some of the most recent and important studies looking at pediatric patients. But a couple of things just to note. There have not been many studies that look at this in kids. Most of the literature is in adults. And in children, it's definitely not as robust and evidence-based because the scenarios where this has been studied is mostly in retrospective studies that are basically collecting data from children that already just coincidentally had a reason to get an arterial blood gas. So those kids are more likely to be sick, or as we'll see, they might be in the setting of cardiac catheterization. And so keep that in mind when you're looking at these studies. And then also you'll notice that even though we think that the mechanism behind the bias that I'm going to tell you about is related to skin color, the pediatric studies are not using skin color as a way to differentiate the groups that they're comparing. So similar to the study that Dr. Ortenberg mentioned, they're across the board categorizing children into either black or white. And so we've already talked about some reasons why that's problematic. But this table is just going to kind of allow you to compare these 4 different studies that I'll mention. This first one is an interesting one because it's in a neonatal population. And they recruited infants that were preterm, less than 32 weeks from the NICU. It's kind of unclear exactly what their age was, but they compared black versus white patients. And here, the mean pulse oximeter bias, so that difference between the pulse ox value and the arterial blood gas, relatively small. In black patients, it was 1.7% of a difference or error. In white patients, it was 0.7%. And then they looked at the frequency of occult hypoxemia, and it was 9.2% in Black patients and 7.7% in white patients, but this was not statistically significant. So not super overwhelming evidence right here. But they did look at sensitivity and specificity for hypoxemia. So how good is the pulse ox at detecting hypoxemia in both these groups? And I'd like to point out that the sensitivity of the pulse oximeter for detecting hypoxemia looks terrible. So it's actually not different here in this study between the two groups, but it was only approaching 40%, which is not super reassuring. But the specificity was higher, which kind of speaks to how we should probably be using pulse oximetry in practice. But that was also, again, not too different between groups. But the next three studies tell a different story, or a stronger story, I guess I'd say. Andrist in 2022 looked at hospitalized children who identified, or parents identified them as Black or white, and looked at blood gas and pulse ox value pairs in children from 0 to 17 years. And they saw a larger mean pulse oximeter bias, 4.3% versus 3.5%, which was a significant difference. But more impactful probably is what they saw for the frequency of occult hypoxemia, which when you just look at the individual test, in Black patients, that value is 9.6, and in white patients it was almost 6%, which was a significant difference. But if you looked at the patient level, like what patients are experiencing occult hypoxemia, in Black patients it was 21%. That's incredible. And then in white patients, it was also not small, but definitely a significant difference between those two. And then the odds ratio of having occult hypoxemia for Black patients was 2.16 times that for white patients. So they're more than double the chance of having occult hypoxemia, which is pretty startling, in my opinion. The next study by Ruppel et al. In 2023, just this year, showed similar findings, a similar age group of 1 to 17 years. Again, Black and white were their comparison groups. And you can read those values there. And then most recently, Savognin, also this year, reported on their study looking at patients hospitalized for COVID-19. So these were children aged 4 to 17 years who were either in the ICU or acute care, but again, they had arterial blood gas values, so they probably were sicker. And they looked at a large number of Black patients and white patients, comparing those. And at the patient level, they found that the frequency of occult hypoxemia in Black patients was 12%, which is 3 times what they saw in white patients, which was 4%. This is the only study of these that actually used any kind of regression analysis to see if they could figure out what's predicting the likelihood of clinical outcomes. And so they tried to see if pulse oximetry bias or occult hypoxemia influenced ICU admission or respiratory support, and they did not actually see that association in this study. And so this little red box is just to draw you back to the fact that basically across the board there is at least a tendency and often like an outright significant difference towards a disparity in pulse oximeter bias and higher levels of occult hypoxemia in Black patients versus white patients. But again, there are holes in this data or in this evidence base because these studies are only looking at Black patients versus white patients as self-reported race. They don't make any attempt to characterize skin pigmentation, which is what we think is probably the major root cause here. And then most don't even describe what pulse ox model they're using, so we can't really figure out if there's one model that's better than another. And then something that's not really well conveyed with just these straight numbers is the fact that while there is a tendency towards this bias where we're overestimating oxygen saturations for Black patients, the direction and magnitude of that bias is actually not always consistent. So there are a lot of patients where it's overestimating, but there are some as well that it's underestimating. And this is not always predictable. And it makes you wonder, and I'll talk a little bit more about that, but it makes you wonder if there are other factors at play, such as the ones that Dr. Ordenberger mentioned, that can influence pulse ox values, such as perfusion and temperature of the extremities and that kind of thing. So these next couple of pictures are meant to illustrate that point. So this is from one of the studies I mentioned, which it's graphing oxygen saturation on the x-axis by proportion of individuals who have occult hypoxemia, basically. And it's a nice graph because it's looking at is occult hypoxemia more common at the higher end of the spectrum versus the lower end of the spectrum. And up at the top, the upper 90s, there's not much disparity here. But as you get down into the lower values, there's definitely more occult hypoxemia across the board, and specifically in Black patients versus white patients. But this might give a slightly more complete picture. This is from Vasulis. This is the study that I mentioned in neonates. That this is just all participants in that study graphed on a bland Altman plot, which is basically, I'm not a statistician, but it's intended to look at agreement between two tests, like how well does the pulse oximeter agree with the arterial blood gas. And the major point here is that this line here at 0 means that there's no bias between the two tests, but anytime you have values that lie above or below that, that indicates some bias. And the question is this bias consistent across the board? In which case, you're going to see a lot of values kind of above the line or below the line. But here, it's got a little bit of a tendency to scatter. There's definitely more points above the line, indicating that we're more likely to overestimate. But there are definitely lots of points below that line, too. And the accuracy, or I guess I should say the agreement, is much better at higher saturations than lower. But this isn't looking at different groups, comparing different groups, but the subordinate study did kind of break that apart. And this is a really similar idea to the last picture, but it's kind of broken apart into a box plot. And it's the same kind of scales on each side. But this is showing, again, that, so we're looking at the disparity here, and it's pretty close when you're at the higher pulse ox values, and then as you get lower, then you start to see greater disparities between the groups. And I'm sorry that this color doesn't, well, there's no color on here, but it's very difficult to tell between. But this is the Black patients at this pulse ox range, and then this is white patients. And so you can see there's a big difference here. And also, it crosses 0, indicating that some of the bias in white patients actually might be in the other direction. This graph also shows that, or shows the kind of area where the FDA has said, okay, that's acceptable, which, as we heard before, was +2 or -2 of a bias away from what the arterial blood gas says. And so our pulse oximeters are only performing in that range at really the upper end of the saturation range. So that calls into question how useful this tool really is. And so this is a lot of interesting data, but there's a lot of issues that still remain. We already talked about the fact that this is, these studies are conflating race and skin color, and that creates some questions about whether, are these studies actually underestimating the disparity because we're not really classifying participants very well, and assuming that Black patients have dark skin and white patients have light skin, and maybe we need to do a better job of figuring out how to compare these groups. However, I will say it's still useful to look at Black groups and white groups in comparison, because if we're looking at health outcomes, that is an important thing to focus on, whether a group of Black individuals may be experiencing worse health outcomes compared to white. But what other variables are at play here? And how are we going to reliably characterize skin pigmentation? There has not been a well-validated method to do this yet. So these are areas of further research. And also, we're totally leaving out individuals other than Black and white in these studies. The adult literature has done a better job of this, and I'll show you a couple of the studies in a minute. But for pediatric patients, this has not been well addressed. And then, aside from skin color, I mean, how is pulse oximeter bias different in children with less severe disease? Because these studies are focusing on children who have just incidentally gotten an arterial blood gas. So that's a lot of information. But one big question is, okay, so this basically is telling us that there's discrepancies between Black patients and white patients in pediatrics, but how do we know what impact this is having on our patients? How big a deal is this? And the gold standard for figuring this out would be we're doing primary research studies, looking at clinical outcomes, or maybe like that last study I mentioned that we're doing modeling studies to try to predict the clinical impact based on the discrepancy, but we just simply don't have that in pediatrics. So I will tell you about a couple or three studies from the adult literature, because I think they are kind of exemplary and can give us a sense of what kind of impact this might have. This one study from Gottlieb et al. Looked at whether pulse oximetry bias led to giving less supplemental oxygen in ICU patients, and they included Asian, Black, and Hispanic, as well as white patients, and they did see that those minority groups received less supplemental oxygen for a given arterial blood gas. There's also an association with an increased odds of mortality for surgical and ICU patients in this study by Henry, who also included a more diverse range of participants. And the odds ratio here for mortality was actually approaching 3 in surgical patients, which is pretty impressive. And it was also greater than 1 in ICU patients. And then finally, this I thought was pretty impressive, that in this study by Sudat et al., they were looking at the likelihood of admission, treatment with supplemental oxygen, or receiving dexamethasone in patients that had COVID-19 who were seen in the emergency department. And they found that that for even a 1% pulse oximeter bias, that led to lower chances of these specific treatments. And so when we think about the impact of COVID-19 in our country, and just the numbers of individuals that were seen in the ED in this exact scenario, you can kind of imagine that this would have a huge impact. So that's all very disheartening. I think there's also other, like beyond the clinical impacts, there's other impacts as well. And I'm sure there are ones that we have not thought of. But this issue is just further compounding the burden for groups that are already negatively affected by social determinants of health. I mean, I think about the child with asthma who already has so many environmental influences on their health. And then when they present to care, their oximetry is overestimated, and then they receive less treatment from that. And then trust in the medical system. If pulse oximeters are overestimating oxygen saturation in people with darker skin tones, this can just reinforce bias. It could encourage providers not to take people of color with symptoms seriously because their number on their pulse ox monitor is not matching up with what they expect to see in front of them. And so I feel that this is yet another example of bias and structural racism that is just piling it on. So where do we go from here? I feel like I've been very negative. But I think there's a lot of opportunity for movement towards fixing this issue and moving towards solutions. And so Dr. Ortenberg and I were trying to figure out how to approach this. And so we decided to rely on people smarter than us who have developed this social-ecological model, which many of you have probably seen before. which was originally designed to try to figure out how to explain health behaviors at different levels, like what are the influences that might change health behavior. But then it's also been used to try to formulate interventions and know at what levels can you influence a problem. And so at the very core is the individual, so individual health providers, individual patients. And then outward from there is interpersonal relationships, our relationships with our patients and families, their relationships with each other. Organizational, the organizational level is next, and that can include Seattle Children's Hospital, the Research Institute, University of Washington. Community is more like the research community in general, or professional societies. Public policy is the highest level where we're influencing policies that affect people across the country, and that would be the Food and Drug Administration or Center for Medicaid and Medicare Services. And so I'll walk through some of these with some of the potential solutions or actions that we can take that we've kind of discovered in our reading. And so I'm going to start with strategies for clinicians because that's where we're all at. And I just wanted to start with the fact that, just to reiterate that what we've seen from the studies is that the magnitude and direction of pulse oximeter bias is multifactorial and unpredictable, and so no consistent rule of thumb is possible. I went into this kind of hoping I would find something like that, and I was so excited. I was like, we can tell you exactly what you're going to do. You're going to just add 3% anytime you have, a dark-skinned patient. But unfortunately, that's not possible. And so luckily, I found a very thoughtful article by Gray et al. In JAMA Pediatrics that talked about how to approach this problem in terms of asking questions when you're confronted with a patient that might be affected by this. So first, is this reading accurate in this patient in front of me that has darker pigmentation, or might the true reading be lower? Could this be hidden hypoxemia? Would the reading be more accurate on an area of lighter pigmentation on the patient? And so these questions are not trying to push you to treat the patient in one way or another, but trying to promote the idea that we need to be taking into account our knowledge of this bias and our lack of knowledge of some aspects of this bias into our clinical decision-making when we're seeing patients. And we do this all the time, so this shouldn't be too unfamiliar with us. We look at the clinical context, we take into account everything that we know, and we put that all into our clinical decision-making process. And so the authors of this paper say that if we carefully consider these questions, it might lead us to be more aggressive in treating individuals that have that may be affected by this bias, more aggressively treating them for hypoxemia. And another potential strategy is to consider an arterial blood gas anytime a patient of darker skin tone has a pulse ox value near a guideline cutoff. So when you're using that algorithm and you've got a decision point where it's dependent on pulse oximetry, just think about, is this something that I need to include into my decision making? And then I would advocate for a discussion with the family. If this is a big decision point, maybe we need to be open with our families and talk to them about, I might decide differently because of what I know about the inaccuracies in our technology, but what do you think about that? And then I would also advocate for using the breadth of your pulmonary exam. So we're pulmonologists. So we all probably learned in school that there is no physical exam finding that's synonymous with the pulse oximetry value, right? We know that cyanosis is not a good indicator of oxygen saturation. However, we have a lot of different ways that we can look at a patient, and we can look at their work of breathing. We can look at them for cyanosis. We can look at their respiratory rate, and so we need to just use all the data that's available to us. And so that solves the problem, right? Unfortunately, I think it's a lot more complicated than that. And so we are not going to fully address this issue on an individual level. I think that's the conclusion we came to, that this is not something that any individual can address on our own. And so we also need to be thinking bigger. And on an interpersonal level, that's our relationships with each other and with families. This is not a solution, but it's something very important that, as I mentioned before, having openness and shared decision-making with patients and families, because they've heard about this. They know that this is out there, potentially. But at an organizational level, hospitals have the responsibility to de-emphasize pulse oximetry as appropriate in hospital policies and prioritize reducing harm over potentially length of stay or other outcomes. And prioritizing reducing harm for already disadvantaged groups, I would say. We also have the responsibility to choose hospital equipment that's had proven better performance in all populations, and especially in minority populations and people of color. Research institutions can support research that is inclusive, that recruits participants of all ethnicities, all skin colors, and disadvantaged populations. Funding institutions can prioritize funding of research on the impact of the disparity, so kind of fleshing out the impact in children, but also, probably more importantly, funding strategies and innovations to address it. So that we're not just saying, oh yeah, this is a problem, this is a problem, this is how bad the problem is, but actually funding strategies to fix this. From a community level, that's like our research communities, our professional communities, spotlighting this problem, and we can all potentially advocate within our professional societies, such as the American Association of Pediatrics, American Thoracic Society, Critical Care Medicine Societies. And last, but definitely not least, this is maybe the most important on a public policy level. The Food and Drug Administration is responsible for approving prescribed pulse oximeters. And so they set the standards for what's approved and what's not approved, and then the rest of the market follows that. And they need to incentivize the development of improved technologies. And the way they do that is that they set these standards for performance, and they need to account for people of different races, ages, and genders. And right now, the requirements for approval for pulse oximeters are, it's kind of ridiculous. They need, I think it was a total of 10 patients in the validation study where 15% or more needs to be people of darker pigmentation. Tiny sample size, not representative, not real world. And so that needs to be changed. And I think it may be only once it gets to this level that we see some actual movement towards developing new technologies. On a positive note, there are some emerging technologies that are trying to address this. I don't know as much about these, but I was reading about photoacoustic imaging, which I had no idea, but apparently when you shine light at a material and it's absorbed, it actually releases sound waves. And this can be measured by photoacoustic imaging. That's this picture here. It's kind of the setup. And a correction equation can be applied to account for skin tone. So that's one emerging possibility. There's also polarized light oximetry. So instead of using non-polarized light in a pulse oximeter, potentially using polarized light can reduce the light scattering effects of melanin on oxygen saturation readings. And then kind of different from these other technologies, but there have been movements towards developing more objective and reproducible methods to characterize skin pigmentation. This on the lower left is the Monk skin tone scale, which has been developed after an extensive amount of field work looking at different skin tones in multiple countries. And so this is starting to be adapted actually by Google in their AI protocols, which is really interesting. And so this seems to have more promise than some of the much older ways to categorize skin color. And then bringing it home is Equinox program. So this is a program that is led by our own Randall Bly of otolaryngology, and also Linga Adidharma and Nicole Gowan. It's a project that was supported by the University of Washington Engineering Innovations in Health program. And what they're working on is trying to develop a pulse oximeter that incorporates a colorimeter, so a sensor that adjusts for skin tone, or that, I should say, that detects skin tone. And then they're working towards developing an algorithm that will use the readings from the colorimeter to be able to adjust the pulse oximeter value for that reading. And so it's a very exciting possibility that could potentially yield a pulse oximeter that accounts for skin tone. And so that is kind of where I'll wrap it up. Just kind of in summary, we've seen that there is a risk of bias in pulse oximetry based on skin color. And it's a very complicated problem, and I think it needs solutions on many levels. I also think that this is a lesson for us that, I don't think anybody intended for a pulse oximeter to discriminate. And pulse oximeters are machines. They don't, they're not racist, right? But the people who design them have their biases, and the people who design them and design the studies that validate them maybe need to be, not maybe, they definitely need to be accounting for a diverse range of people, and not focusing only on white patients, but making sure that there's accuracy in all different groups. And so as we move forward and developing new technologies, we need to be aware of this, and we can intentionally decide that we are going to make sure that we don't allow unintentional bias to creep into new technologies, new algorithms. And I think that's one way that we can work towards better, equitable care for all children.
Hi, thank you so much for this talk. I think this is really important. You kind of touched this in the last slide, but I think a wrinkle I think about with pulse oximeters that differs from addressing structural racism in like algorithms like EGFR or PFTs or things like that, well, actually, is that it includes a device that is likely patented and manufactured by a private biotech company. So I think about spirometers, and even though the ATS has recommended removal of race from PFTs, you still have all these spirometers out in the world that differ in their racial categories by country, and it's just really hard to standardize. So I guess, do you know of any efforts, or do you feel like there is a role in also partnering with like the private like biomed sector, both in like innovating forward, and then how do you kind of rectify the pulse oximeters that are already out there?
Yeah. That's, I think that's an example where I think that multiple levels of attack is probably useful. I think that the technology companies are incentivized to create their pulse oximeters according to standards that the FDA sets. And the FDA is influenced by physicians and advocates and the research that's been done. And so partnering with technology companies seems like an excellent way to go about it. Dr. Bly's group, I mean, they're basically creating this technology where they are intentionally trying to attack that. But yeah, there are going to be pulse oximeters in the world that even if we come up with a new pulse oximeter that's perfect at measuring oxygen saturation, yeah, that's just, I think, going to take time to kind of disseminate better technology. But I think that the major force for change is probably going to have to be from the FDA, that changes the standards for approval, which then incentivizes the companies to innovate. Yeah. But then we can have the voice in telling the FDA that this is what you need to do.
First off, I just want to thank both of you guys, Dr. Ortenberg and Dr. Crocker, for giving this important issue visibility. I think the more that we acknowledge that these disparities exist, identify them and talk about them, the better chance we have of actually doing something to remedy them. So I applaud you both for being brave and talking about this issue and bringing it to the visibility that it deserves. The question that I have is, one of the suggestions that you had is to have some shared decision-making with patients and families in the moment. That if you're seeing a patient in front of you and their pulse ox is borderline and it's going to impact your clinical decision-making, you talked about having a conversation with patients and families about this issue. How do you recommend that happen? Because oftentimes it's in the heat of the moment, you're in the ER, you're in the PICU, and that's a difficult conversation to have. So what tips do you give everybody in the audience about what do you say, and how do you have a productive, sensitive conversation where you engage the families to try to help to get to the right decision?
Thanks, Terry. I think that's an excellent question and kind of the heart of it, and something I struggle with anytime that I'm confronted with an issue like this. And I think I would probably learn from you about the strategies to take. But I guess one thing that I think of is trying to get myself in the right mindset in terms of thinking about putting the patient's needs first, and also trying to, be introspective and understand my own biases and where I might be coming from.